Hello folks, Dr. Kazmi here. Asthma remains one of the most common chronic illnesses in children worldwide. Over the past decade, we've witnessed significant paradigm shifts in how we approach its management, particularly in mild to moderate cases. The year 2025 brings further clarity and clinical confidence in two relatively newer strategies: anti-inflammatory reliever, or AIR therapy, and maintenance and reliever therapy, also known as MART. These approaches move beyond the traditional reliance on short-acting beta agonists, or SABAs, focusing instead on timely anti-inflammatory intervention using combination inhalers that contain both inhaled corticosteroids, or ICS, and formoterol, which is a fast-acting, long-acting beta agonist, or LABA. The concept of AIR therapy is deceptively simple yet powerfully effective. Rather than reaching for a SABA inhaler like salbutamol during asthma symptoms, children aged 6 and above are now increasingly recommended to use a low-dose ICS formoterol inhaler as needed. This means that every use of a reliever inhaler also delivers anti-inflammatory treatment, a principle rooted in modifying the disease course rather than simply masking symptoms. The 2025 Global Initiative for Asthma, or GINA guidelines, have formally included this approach in Track 1 management for children aged 6 to 11 years. Though, most of the pivotal studies to date, like the SIGMA trials, have focused on adolescents and adults, observational and pragmatic trial data suggest similar benefits in the pediatric population. These include a reduction in severe exacerbations and a decrease in overall inhaled corticosteroid burden, as steroids are only delivered when needed. Clinicians should be aware, however, that in many countries, the use of ICS formoterol inhalers as sole relievers in younger children is still off-label. Nonetheless, with appropriate education, monitoring and consent, it is becoming an increasingly accepted off-guideline option in well-selected cases. MART, short for maintenance and reliever therapy, takes this concept a step further. In this strategy, the same ICS formoterol inhaler is used both for daily maintenance and as needed symptom relief. This not only simplifies treatment regimens, but also improves medication adherence by reducing the number of inhalers and steps. In 2025, GINA continues to support MART for children aged 6 to 11 at steps 3 and 4, provided they can reliably use the inhaler and understand its dual role. This approach is especially suited to children who experience frequent symptoms or exacerbations, even though they're already on standard fixed-dose ICS plus SABA. Emerging pediatric studies from Europe and Australia in 2024 and 2025 have shown some really encouraging outcomes, like reduced emergency visits, lower cumulative steroid use, and, improved asthma control. One key real-world advantage is that MART ensures children are protected even when they self-medicate during early symptom onset, which is honestly often when the risk of exacerbation is highest. That said, MART is not without its caveats. Dosing caps, often 8 to 12 puffs per day depending on the child's age and the formulation, must be clearly emphasized in written asthma action plans. And of course, the strategy requires thorough caregiver and patient education to prevent both underuse and overuse. But the 2025 GINA guidelines remain the most authoritative resource on this subject. Notably, they recommend AIR therapy as a preferred reliever from step 1 for children aged 6 years and older. MART is suggested for those at step 3 and above who have uncontrolled asthma or frequent exacerbations. Similarly, recent updates from the British Thoracic Society and the Primary Care Respiratory Society in early 2025 have echoed these sentiments, highlighting AIR as a viable alternative even in primary care settings. While many of these inhalers are still not formally licensed for children under 12 in some regions, off-label use continues with increasing clinician confidence. While AIR and MART therapy represent significant progress, they are not silver bullets. The success of these strategies really hinges on correct inhaler technique, which often means using spacers in younger children. It's also important to have updated asthma action plans that are tailored to these regimens. We need to keep an eye on adherence and watch out for signs of overuse, especially with MART. And of course, shared decision-making is vital, particularly in off-label scenarios. Moreover, ongoing trials focused specifically on children under 12 are eagerly awaited. These studies will help address the remaining questions about long-term outcomes, growth effects, and, figuring out the optimal dosing schedules. The 2025 landscape of pediatric asthma management reflects a broader philosophy shift, from reactive symptom treatment to proactive inflammation control. AIR and MART are really at the forefront of this movement. For clinicians, this means rethinking traditional SABA prescriptions, educating families about dual-role inhalers, and aligning practices with the latest guidelines. In selected children, particularly those aged 6 and up, AIR and MART strategies offer a safer, more effective and patient-friendly alternative to conventional asthma care. The challenge now lies in implementation, making sure that every child breathes easier with fewer interruptions to their health, play and learning.